I thank you once again for the honor and particularly to be able to deliver this address to you. To be in the presence of a true pioneer of your country with the reputation of Professor Khanum is a rather humbling experience to see the progress that's been made and the achievements he's made, and I'm honored to be here. The assignment here is to look at the future way of endografting, and I always like to think about the past, the present, and then wonder what is going to happen in the future. I had a very interesting experience a few weeks ago at Charing Cross, where the early historic work of Dr. Volodos from the Ukraine was presented. And what was amazing was that almost 10 years before Juan Perotti was able to do the first endograft and get published, this Ukrainian surgeon was doing miraculous kinds of things with endograft technology and stents and so forth. So sometimes we think we're making great progress, and people in the past have really had some tremendous contributions to what we do. I think it's clear to say that one of the most dynamic areas in endovascular today is the growth in EVAR. Professor Giorgio Biazzi at our meeting a couple of months ago showed this slide, which indicated the real increase in endovascular just in a 4-year period, where over 70% of the aneurysms are treated with EVAR, and I think that's going to increase. There's no question, this is being fueled to a great extent by industry. Over $1 billion annually is the world market in the endovascular technology in thoracic and abdominal. The endovascular specialists are making efforts to expand EVAR to even a wider pool, to take on more difficult necks like the case we just showed, short necks, angulated aneurysms, calcific arteries, and troublesome access and so forth. These are a few slides. The next few slides are the source of this is the Millennium Research Group. And what they're showing here is, in this particular slide, the tremendous increase in terms of the amount of revenue being generated. And when you look at let me get this working here. When you look here, you can see that in there we go. In just a few years, 3-year period, you're seeing leaps of millions of dollars. This is a really interesting slide. This is about the economics that we call Obama healthcare. I'm not sure how much you folks have been thinking about that or doing anything about it in terms of what's going on. But he has placed a tax, a proposed tax, on every device that's to be sold. I just received an email this morning from one of my colleagues back in the States, and the U.S. House yesterday denied the tax. So it's going to go to the Senate. So there's still a possibility that they may not do this. But it is causing all kinds of problems. The CNN report just last week, I was listening to this, a major Massachusetts company laid off 43,000 employees worldwide and is transferring operations outside the United States because of this problem of the tax. This shows that the abdominal aortic procedures are going to continue to grow, and you're going to see this gradual decrease in the open cases. The same thing has occurred in the thoracic area. See the thoracic grafts going up. Fewer thoracics are going to be done. This just shows indication for trauma and all the other indications that are, as I said earlier today, I think that the endovascular technology for type B dissections will be the gold standard in the future. So we ask, as we're moving on in the future, what are the parameters for success, and what are the things that are really critical? Well, we've heard about endoleak today a couple of times. Migration, elimination, seal, durability, profile, radial strength, proximal and distal, hydrophilic coatings, conformability, positioning, deployment control, and so forth and so on and so forth. And in thinking about this, thought, well, what does industry, the device manufacturers, respond to these various challenges? So I went through all of the current devices that are commercially available, and I looked at their advertising to see what they were promoting and how they were having differentiators. So we look at Medtronic. Medtronic is pressing the fact they have a seal, they have conformability. Anaconda, it has repositioning. It has the blue glide, which is the hydrophilic coating. I looked at Gore. They talk about their natural approach, conformability. I looked at Medtronic again in terms of their endurance. This is the world leader for sure with 56,000 implants. They're proud of this. Medtronic also with their Captivia, which is controlled deployment, which you see being repeated here. APVIC, which is the new Endologics. They have this new material called Strata. It's a wonderful material. You get seal with this and conformability. And you look at the tag from Gore, and what do they stress? They can use it in transection. It's the only one approved, but they talk about conformability. Cook has the ARC technology. I had to really look that up. I wasn't sure what it was, but it is really a technology that prevents migration. ARC equals anti-migration technology. Ovation, one of the newer grafts coming out, they have the polymer-compatible fill at the proximal ring to try to stop endoleak for fixation and seal. So when you go through this and you look at every one of the companies, you ask, what does this really tell us? And it's kind of gibberish here. That's why I don't have anything in the numerator. And I wonder if aren't all the clinical results worldwide very similar, regardless of the device. And so I asked, what would Shakespeare say about this? And I guess he might say, much ado about nothing. So are we reaching a state of device equipoise? The data suggests to me minor non-consequential differences in the current device performance. They all look about the same. And when you look at the reports on these, they all really do about the same. You don't see much difference. And then I've always wondered, as the device technology became at an equipoise level, wouldn't there be some economic positiveness? Well, that turns out not really to be the case either, because if you know from country to country, and in your own country, the price of these are all about the same. There's equipoise. Now, there is some competition. I think sometimes in the back room, the salesman may make some manipulations and you get a better price. But in spite of what may be a state of equipoise, there are unmet needs today for EVAR and also for TVAR. And we've talked about these. We've had nice lectures on this, and I think you're all acquainted with what these are. So as we move forward, one of the things that's occurring is there's so much excitement about these devices that the cases are being done off protocol. In fact, we call that outside the indication for use, the IFUs. 65 or 70%, maybe greater in our country, EVARs are implanted off-label. And that is causing some really serious repercussions in terms of complications that occur. In fact, the majority of complications we see in these grafts today are because they're done off-label. So probably we should consider the IFU use only in unfavorable anatomy where the open repair outweighs potentially higher risk for the EVAR failure. And then I think in the future we're going to see this occur, and whether it's going to be voluntarily or whether it's going to come through government and regulatory control, which is what I predict. Complex anatomies should be treated by expert high-volume endovascular centers. And I have a strong feeling that regionalization is going to be a component, at least in our country, in the not-too-distant future. Now, what is being done to overcome this, what we might call abuse of the IFU, and how are you getting new approaches? You heard about the hybrid approach, where a hybrid really means we're extending the landing zone so that we can move an endograft into that better. Well, one of the areas we were very interested in the beginning was the ability to do a surgical procedure. Hybrid is a surgical procedure and an endovascular procedure. And we were very excited about this in our own group, and I did a series of these. There's no randomized trial, small case volumes, application of a variety of techniques, so no uniformity, no commercial products, of course, and it requires customization. But what we found, in spite of our enthusiasm, these are complex procedures, and we had significant morbidity and mortality. And this, I think, is what I found as I traveled to other centers and talked to investigators. I think it's very unlikely that this hybrid type of approach here in the abdominal aorta is going to be the answer for the future. But clearly, there's a lot of interest now in juxtarenal and pararenal aneurysm. You know, a juxtarenal aneurysm is one that comes up to the renal artery, and a pararenal is where the aneurysm involves the renal arteries, distal to the superior mesenteric. So this is a nice example. Here's a pararenal aneurysm involving the left renal artery. There's a lot of active research and device development of this. Several companies, Cook has the Cook fenestrated graft. It's just approved, customized in the United States. Endologics has the Ventana, which is under clinical trials. Medtronic is still in design. They don't have anything. And Vascutek has a custom-made graft, looks like this, but it is only by special order. It takes about, I don't know, 6 or 8 weeks to get it. We've heard during this meeting about the chimney stacks. We've heard about the snorkels. We've heard about the periscope. We've heard about the sandwiches. I call this the smorgasbord of options for thoracoabdominal aneurysms. And the results are variable and they're inconsistent. And I don't think we know the true mortality, morbidity, and outcomes related because we don't have good control over this. But my opinion, when you see so many options to treat any particular pathology, the best is still in the future. And I think that's where the challenges are. We don't have the answers to that yet. Now, if you look at the thoracic aorta, I think the potentials for TEVAR have been established much better than perhaps the pararenal and the juxtarenal are. And there's worldwide interest in this. I just listed here a variety of the pathologies where we have had, over the last 6 or 7 years, a lot of experience and excellent results. And I think I think most people agree that in the majority of these areas, we can get excellent results with the endovascular technology. I do list in red here esophageal fistula. We did 7 aortobronchial fistulas, and we published that material because we were so shocked that we got the good results, no infection, and so forth. We extended the idea to esophageal fistula, and it's a total disaster. That is not an endovascular approach. Now, in spite of the positives of this, I just had this slide. I thought I'd put it up. It was a slide of the ERIC Symposium in Vienna last year. And you look over here, all the controversies you're still having, controversies in root and the arch and type B dissections. I think we're going to resolve that, and fenestrated and so forth. So in spite of the development, I think that there still is a lot of controversy. Now, the initial emphasis has been on zones 2, 3, and 4, and some encroachment on 1. And there's going to be, obviously, some great interest in the type A, and that we talked about this morning. Let me give you a couple of examples of why we are looking at this in, I think, a positive way, but there's always skepticism. For instance, transection. Transection today, the preferred treatment for sure is endoluminal graft treatment. There's no long-term follow-up. There's no commercial products, although the GORE is now one that has approved. Superior results, no level 1 evidence, and there will be a controlled study. This is one of our cases. We started this very, very early. This is a case 9 years after a transection. We made a customized graft, which of course is what we had to do for all these early cases. I mentioned no consensus. Spinal cord drainage. There is absolutely no consensus about spinal cord drainage as you travel around the world, and one investigator will say this and one say well another. There are some indications. Routinely would use it in compromised subclavian, compromised iliac, extensive thoracic, and so forth. But really, no consensus, individual protocols, and we never will have randomized studies. A similar thing in left subclavian, when you cover the left subclavian. When we first started to do the thoracic graft, we did a carotid subclavian bypass on every case. And then we found that some of our European colleagues weren't doing that. So now, if the left vertebral is critical to the posterior circulation, previous AA, internal iliac status, and so forth, we might use it. But once again, no consensus. What I do believe there is consensus on, the large database, and this comes from the Texas Heart Institute watch, indicates their endovascular repair of descending thoracic aortas is a positive. And even Dr. Corselli, who is the master of the open technique, is coming around and indicating that he thinks there's a place for that technology. Now, here is the challenge for the future. And I think this is where there's a lot of work and a lot of thought coming into it, because there are no commercial products and it requires customization. And we've had a few cases like this where you can put a customized graft, and I showed you one of those in the earlier lecture. The companies are coming up with side branches. This is one of the Gore side branches. This is a single side going to the subclavian. You can switch it over and you can go into the innominate. Cook has a graft coming along. You saw the very, very beautiful chimney stack cases this morning. I was very impressed about that. And you also saw the hybrid procedure where we're rerouting around to extend the ability to do the procedure. This has become a fairly common procedure now, hybrid, where we sew a graft onto the ascending. This particular case was an ascending which put onto a previous graft that had been type A, had been treated, rerouting, and we're getting very good results with these. The problem is, as we get closer down to the sinuses of Valsalva here, and this kind of an aneurysm I showed you earlier, then we have the problem of aortic disease in addition. If you just look at this oblique view here, you can see there's a lot of activity that goes on from the coronary arteries to the sinus of Valsalva, to the tubular sinus junction, and to the ascending aorta here. So this is a very complex area. And currently, this demands the open bental operation, where the aneurysm is resected. You put a valve replacement in. For those of you who are not cardiac surgeons, not familiar, you have to treat the coronary arteries either by direct replacement, buttons, or you can put a graft on. It's an option. Now, as you look toward the future, this is pretty exciting, because percutaneous valve in the aortic area is a reality. It's big in Europe. It's, I think, approved for almost a routine basis now. We now have a biologic component of this, which has this big potential in the future. So if you look at this is the most complex thing. Would we be able to treat this kind of disease with endovascular technology? Well, I think we're going to be able to. We have percutaneous valves, we have coronary inserts, we have ascending grafts. These grafts have branches, we have neural protection, we have a special stent we can put in to straighten the artery off. But this is going to be a problem for us, because if we don't have some way to take care of this, we're not going to be able to solve it. So this is a little sketch we're working on. We're thinking about how we might be able to do this. We have Joe stents, they would work. We have open space, though. We've got to do something about that. So then it could be a little difficult to deliver those coronaries. But here's the question you ask. Could we put a device that could cover these coronary arteries and not occlude them? And this is what you're going to hear about later on. And this is the multi-layer stent. I'm not going to show you much about this. A thoracoabdominal aneurysm. Here the aneurysm is a month later. And here is the work we did in the laboratory. We put the graft across the arch, and the arch didn't occlude. We did a case, Dr. Buckley and I did a case 9 months ago. I'm just going to show you what this was. Ascending aortic aneurysm. Here we are on the table in this Modena, Italy, where we did this case. Here is the multi-layer stent coming from the sinus of Valsalva all the way across the arch. Coronary arteries are patent. 9 months later, here is the study. The patient's asymptomatic, this aneurysm shrunk. We did a finite analysis, and this shows beforehand severe potential for rupture, and here, 9 months later, no rupture. So The past of EVAR has been early detection, less invasive therapy, cost reduction, uncomplicated longevity, but device development has been and will continue to be the key component in the foreseeable future. However, as I close, I want to talk about this. The future is going to be about genomics, proteomics, and cellular therapy, because they will begin to invade this space. We saw at the Charing Cross meeting the LRP1 gene for abdominal aortic aneurysms. We know now that there are certain gene patterns in the carotid plaque. We know that the biobanks can play an increasing role in getting biological samples to work also with the clinical characteristics for scientific medicine. We ask what aneurysms to operate upon, when to operate, what operation to perform, what are the non-operative options, and many more questions. Well, the answers, folks, in the future will reside in this enormously powerful biological arena. Epigenomics is that science that involves the study and changes and regulation of gene activity independent of the expression of the genes that are not in sequence. This is focusing on how genes can be turned on and how genes can be turned off. Epigenetic changes, such as histone modification and DNA methylation, can alter the expression of genes identified in aneurysms. These epigenetic alterations can stem from known aneurysm-related risk factors. This is where genomics comes in, like smoking, aging, and inflammation. And understanding the human genome and the science of epigenetics is going to influence how we will make detection, treatment, reversing the pathologies, and preventing the falls in the future. This is, I think, the way forward for EVAR and TVAR. Thank you very much.